Casey. I do a good amount of joint replacement here and a little bit over at RGH2. I've been using the robot for knee replacements since it got here, which was, I think, August or September of 2020. I think it's been great so far. I think it's good to get some information out there about it. We got the ROSA, which is the Zimmer product first, back in August of 2020, and we just recently got the Depew product, which is called Bellis. And we'll go over both of those today. I have a PowerPoint of kind of what we're doing, why we're using robots to begin with, whether they actually do anything, and whether there's an actual point to having them. And then I have, we'll leave some time for questions there. And then I have some videos to show you guys what we're doing in surgery that's different. And then we'll talk about what's different for everybody who's taking care of the patient afterwards, which essentially is nothing. Sometimes there's an extra small incision, but for the most part, the postoperative care is the same. The question is whether patients do better or not. We'll talk about that a little bit. All right, so two products in this system. First, on the left side of the screen is the Bellis robot. That is the Depew product. It is newer. I think as of right now, Dr. Klotz is the only one using it. On the other side of the screen is the ROSA robot, and they kind of have similar ideas to them. There's one station that is for monitoring the patient and gathering data, and the other station is for computing and doing stuff to the patient or helping us do stuff to the patient. So in general, there's two stations, one with the camera on one side of the patient, and then the robotic arm is on the same side of the patient. The Bellis product clips right onto the table, and then it's got a saw attached to it, which is kind of nice. There's no cutting jigs, no cutting blocks like we'd use in traditional arthroplasty. The ROSA product is more of an arm that has a guide on it that we cut through, so it's more of a little closer to a traditional knee. Rose is a much bigger girl. She's about 800 pounds. She wheels around the room. Bellis is a little smaller, more compact. So why bother with a robot? Well, are we trying to get more accurate implant placement? Of course we are. Are we getting better outcomes? We'll talk about that. Are the x-rays better? I think so. Do the patients recover faster? Does it cost less? And does it make my life easier? And we're going to touch on each of those here. I have a few papers. I did a quick search and I limited it only to Journal of Art. Oh, wait, we'll do this first. I did a quick search, limited only to Journal of Arthroplasty in the last 6 months, and there's an incredible number of articles. This is the new hot topic in joint arthroplasty, especially in knees, and there's a lot to talk about. But first, let's talk about our implant placement and radiographic outcomes. I would say definitely the x-rays are prettier coming out. There's not a lot of outliers. Implants go in the right spot more reliably with a robot, and I have some papers to show that. But what are we trying to do? What are our guidelines here? And our guidelines are, we want a straight leg. So this picture all the way over here, you can see the hip to knee to ankle is a straight line. This is your valgus knee, and this is your varus knee. So correcting this without a robot, you can do it, but it's often hard to get that full picture of the entire extremity. So the robot uses different data points, and I'll show you their collection to create this straight up and down line, which helps the patient. It gives them a more mechanically ideal knee. And then it also helps the implants because if the forces are evenly distributed, it should last longer. That's our goal globally. A little more focused is to create these rectangular spaces. So we look at the knee in 90 degrees of flexion and at 0 degrees. And we just want those to be rectangles that are equal in size. And that's because the implants are a certain shape and you need to create enough space for the implants to fit it. It's simpler than we make it sound often, but this is kind of the goal. And the goal here is to make these so that you can make these cuts so the implants fit on the end of the bone and you have a knee that works for the patient. So first, does this help us put implants in a better spot? The short answer is yeah. There's a few different papers. This is one that I just picked just from recent. I think this was 2 years ago. Yeah, it does. It makes the x-rays look better and the implants are in a better spot. Here's another one looking at long-term clinical and radiologic outcomes. This one says it doesn't, but this is an older study. So what you'll find in a lot of these papers is that the older papers don't show much of a difference. They say that robots aren't any better. Why bother using it? And as more evidence is evolving and as we've been using it longer, robots are doing a lot better. A lot of the older data is from the Stryker, the Mako product. And that's not because it's an inferior product. I think it's a great robot. We just don't have one here, so we're not going to talk too much about it today. But that was the early part of robotics, and then these other robots have come out since then and, in theory, made improvements, although that remains to be seen. So this study says, no, it doesn't, but it's a little bit older. And I think I have one more. I don't. That's the only one. Those are the only two I put in there, but there's a lot of them. There's a lot of different studies that say your x-rays will look better and the patient should, in theory, be happier because of that. So better outcomes, faster recovery. Early data says no. Recent data says, yeah, it's starting to look like the patients do better, both short-term and some are even saying long-term, but the Velis robot came out less than a year ago, so we have no idea what the long-term outcomes look like there. ROSA's only been out for a couple of years, so the most data that we can have is a couple of years. The Mako's been around the longest, so that's the one you're going to get most of your long-term data from. So yeah, Velis is new, ROSA's new, and again, Mako's kind of the gold standard from a robotic standpoint as far as longevity is concerned. Does it cost less? Yeah, probably not. Long term, if we put implants in better spots, and if that makes implants last longer, and it makes patients happier so that they don't need revision surgery, they have shorter hospital stays and quicker recoveries, it might become cheaper, but for now it's almost certainly more expensive. But that's okay. And is it better for me? And this study says yes, and I agree with this. This is kind of where I'm at. I'm a new surgeon. I did not do a fellowship. I came out here and I started doing a whole bunch of knee replacements. And you can ask any surgeon who hasn't used your robot and who started out that there are going to be implants that end up in some spots that you weren't trying to put them in, despite your best efforts, no matter what you do. And I think that this certainly has helped me eliminate any outliers in my knee replacements, especially the primaries. I just think it's a great technology for that. I sleep better at night, and I think my patients are doing better. I mean, it's completely subjectively. I don't have any data to prove this, but my patients who get a ROSA seem to do better than my patients who don't. And the way I know that is I had a brief period of time where I wasn't able to get the ROSA for scheduling reasons, and I used a different product, a navigation product, and I just think the patients didn't do as well. I think robotic knees in general are the wave of the future. They're going to help. So yeah, so I think my patients do better. I feel better, no outliers. A few things for the patients. The Stryker product, which we don't have here, they require a CAT scan before their robot, before they have surgery. The ROSA has an optional dedicated calibrated knee x-ray that's needed that you can use before surgery to help their planning. I do not use that. You can also do it without it, and it in theory comes out exactly the same. So I don't do that, and I don't think anybody does anymore. I think when they first got here, everybody was trying to do it. Turns out it's a pain in the butt. Doesn't really help you that much. And then as far as differences for the patient, is the extra pin sites. So when the ROSA first got here, the official recommendation was an extra incision on the thigh and an extra incision over the tibia to put pin sites in. Those pins hold arrays that the camera can see. That's for that second piece. And that's how it gathers its data. As that has evolved, I think just about everybody's putting their femur pins inside the incision because putting a pin through the quad is not particularly pleasant for the patient. And I think a lot of people are now putting the tibia pins inside the incision too, which requires a little finagling on our side. I personally am down to one extra incision, 2 tiny pokes right on the front of the tibia. Those heal up just fine. I haven't had any problems with those yet. But that's really the only exterior difference you see. And then, of course, the difference that I think they're doing better. All right, so I have, let's do questions first. I have a video. I have videos from both products, so you can kind of see the difference between them and what we're doing, but I'll open it up to questions. I imagine you guys might have something to talk about.
There's nothing up on it.
Nothing?
Nothing.
Unbelievable. Nothing. Yeah.
I might have missed it, I'm sorry, but is there specific criteria for the patients that you choose the robotic versus not, or are you just like?
Yeah, I do them on everybody.
Okay.
as long as there's a robot available for me to use. We have two. So we have one ROSA, which is the Zimmer product, and one VELS, which is the DePuy product. And there's rumors that there may be another one on the way, but I don't know how real that is. I'm not sure. There we go. All right. The rumors are everywhere. But yeah, and I think most people who are committing to robotic knees are just saying, you know what, I'm doing it in everybody. The amount of people doing it selectively is pretty slim. There are certain people who don't want to use a robot, but if they get a patient with, say, a femur deformity and we can't use standard instrumentation, all right, great, they'll use the robot for that case and then go back to the normal stuff.
Are they doing the ROSA at all the sites? RGH, Clifton?
There is a ROSA at RGH, there's a ROSA at Newark, and there's a ROSA in Batavia. I think those are the only three we have. Wait, four.
If somebody does come in for a knee revision, and you ROSA under revision, or is that something different?
So there are times when a ROSA can be used on the revision. If there's too much bone loss, it makes it a little harder. I know Dr. Wagner has been doing a few revisions with the ROSA, and he's had some great success with it. I haven't gotten into that yet. He does, I mean, he does these way more often than I do, but it is possible, whether, depending on what we're doing. If you take a patient who had a uni compartment on the arthroplasty where they just had the medial side done, it works great. If you get into somebody who's having their second or third revision and there's some bony issues, I would imagine it's probably different.
All of your rates of post-op infection compared to conventional.
Yes, so individually, the sample size is certainly not big enough to say anything. I think I've only had one patient with a infection, but it was somebody who fell on their knee and split it open. So that's not really an infection, it's more of a wound dehiscence. As of right now, I don't know that I've had a ROSA get infected. Maybe one in the last 2 years. And I think the data, if you go through the journals, says it's the same. The pin sites don't really make a difference, and especially if you're putting the pins within the incision anyway, then you're not even having an extra spot for infection.
Just the questions on mine.
Yeah.
I'm curious if patients are allowed to run post-op as more people are staying active post-surgery. So that's one question.
Okay.
And-
Let's do one at a time, so
Okay.
I don't forget one. So the short answer is, yeah, I guess. Not related to the robot. That's just related to the knee replacements. You know, I think keeping it low impact would increase the longevity of the implants. I don't recommend running as a hobby for patients who have their knee replaced, but if that's what they do, you know, maybe they can take some time on an elliptical or maybe start cycling or something like that. I think that's probably a better option. I don't tell people not to run, but I haven't had anybody tell me they were marathon training yet. So
The next question is the robotic surgery covered by insurance? And also, is there any time difference in the length of surgery with the robot versus a traditional?
Yeah. Great question. So the cost to the patient is the same. Even if you need a CAT scan or an X-ray ahead of time, that's usually covered by the company that makes the robot. So the cost is no different. Insurance does cover it. As far as time for the surgeon, there is a learning curve. I think initially I was about 20 minutes slower with the robot. Now I'm down to about 5 minutes slower with the robot, which for me is, I mean, negligible. I mean, there are some pretty high volume people who probably care about 5 minutes. I personally don't. To be honest, I don't think they do either. I think that the data and in getting the feedback that we get from the robot is worth 5 minutes, even 10 minutes. But yeah, it does take longer, but I think it's a better product. So I don't have a problem.
And another question, have you noticed a difference in progress with range of motion and strength post-op when using the ROSA?
Completely just subjectively thinking about it. Yeah, I think my ROSA patients are better. I had a brief period where I was using navigation, and I've had a few stiff knees, a few people that need manipulations, and a few people that are struggling from that period of time. And since then I've switched back and everybody's doing better again. So there are probably a lot of variables to that, but that one is easy to identify and seems like it's certainly helpful.
Is the implant the same whether you use ROSA or traditional?
Implants are the same. Yep, doesn't change anything. All right, so let's do some. I'll show you guys some stuff. I'm going to be kneeling down, clicking the video here because I have some.
I know. Here's a pad.
Oh, great. I have some parts of it. It's like an hour video, and we're not going to sit here and watch an hour video. So now I need to do. Let's see, how do I the meeting? I need to share a different screen now. So let me get rid of that, and I can do. Let's see, my internet screen. Share. Okay, great. I had each implant company kind of send me a couple of their videos. This is the Zimmer surgeon training video. So I'm just going to fast forward here to some select spots, if it will let me. So this here, the point of this was, this is where the pins are supposed to go. Lost it a little bit there. I'm just going to move back. But you can see here in the thigh. So here's essentially the pins going in. So 2 here in the tibia, and then there's 2 up on the thigh. Again, this is what it looks like if you put the pins outside of the incision. This surgeon chose to put them in before they even put the tourniquet up. I usually do it after I make incision and have everything all set up. But again, you're not going to see a lot of incisions on the thigh, because I think early we saw a lot of people who had a lot of pain in their quad from stabbing them through the quad. So then the next thing I want to show you guys is some of the 651. So then here, attached to those pins are these arrays. And what these are, this is just something that the camera can recognize. So that second piece of the robot, these are the things that it sees. And using these arrays, there's one on the femur, one on the tibia, it's able to tell you or figure out what the knee is doing and create that axis that we showed you in the beginning and create those rectangular boxes that we talked about. So then the part that takes the longest for us, and this is what we're going to show you here, is there's a process of registering the knee. So you can't just put those pins in the arrays on and then the robot knows where the knee is. So then you need to use some special pointers and you move the leg around to figure out so that the robot can calibrate where the hip, the knee, the ankle are. So here he's moving the leg in a circle. What that does is it finds the hip center, which helps it create that axis. And then we're going to add extra points in along the femur, along the tibia, and along the ankle so that it can create that straight line for us. So this is that was how you get the hip center. You pick a couple points on the femur. They're going to run through that. We don't need to probably watch the next 5 minutes of this because it does take some time. But you can see we have this pointer, which finds the spot, and then the robot goes on to the next point. And we use this to find the posterior condyles of the femur, just a special thing to go in there. And then we go back to pointing at different things around the knee. And in the VELOS video, you're going to see a similar process, although I think theirs is a little more fine-tuned than this one. I think this is a little bit more, I don't think it's as efficient. All right, so we'll jump forward here. We don't need to go through all the different points, but they do the femur, and then they move over to the tibia. And let's see, 1423. So here is part of the planning screen from the robot. This is what we talked about. So this patient had a 12-degree varus knee before, and now if you go through with the plan with the robot, it's dead center, 0 degrees. You can play with the numbers on that a little bit, and we'll go through that in just a second. which can change that a little bit in either direction, but in general, you're aiming for 0. 60 minutes. Then we fast forward, and this is our planning screen. So once we've gathered all our points, we start to look at the knee in extension and then at 90 degrees of flexion. And each of those spaces, we want to make it a nice equal rectangle. So this gives us our data here. So this, using the tensional ligaments that we've tested before and the points it took, it says, okay, well, if we do their plan, we have a 16 millimeter space on the lateral side with 7 millimeters of ligamentous laxity. So that makes 23 millimeters. And on the medial side, we're at 11.5 and 4. So you can see that we're a little tight on the medial side of the knee. And based on that, we can change, we're all the way over to flexion. Okay. We can change different parameters of the implants on this planning screen before we've done anything. So we can rotate the implants, we can flex them, we can extend them, we can move them forward and back in all different planes to figure out exactly how to make that a nice rectangle. So that all this is done before we even make a cut on the patient, which is kind of nice. And then to what it looks like. Oh, there, he just flipped over to the extension gap. So again, similar thing, you're trying to make them both rectangles and you want them to be about equal if you can. So then we'll get into what it looks like for the patient. So now we've made our plan. We've told the robot what we want it to do. And then the arm is going to come in. The ROSA arm comes in a painfully slow manner. So you can see the little cutting block coming in, nice and slow. Then you sit there and you wait for it, and you wait for it, and you wait for it, and it finds its way. And then you bring it in closer to the patient. All right, so you pin it in, so you stick it on there. Okay, now we're going to make our distal femur cut. It's got its little boxes on there telling us that we haven't made a mistake. We put pins through that cutting jig, and then we just use a standard saw like we'd use on a normal knee replacement to cut the distal femur. Should get to that in just a second. They really take their time in this video. See if we can fast forward a little bit. All right, so the pins are in. Should be getting to their saw.
Will you allow us to see the whole video, like when you send it out?
Yeah, so the video link is at the end of the PowerPoint if you want to send that out. It is a Zimmer Biomet TV video, so you may have to sign up for a Zimmer Biomet account. Well, I'm using Mike Fusili's username and password, so you can have his. All right, so you saw there they use the saw, they make their cut. They do something similar for the proximal tibia. The robotic arm comes in, painfully slow process. It's interesting because these surgeries, they don't take that much longer. It's just about 5 minutes, and you spend a lot of time waiting for a computer. So it's actually a lot easier on the surgeon. You're not doing as much. Well, it takes the same amount of time. I don't think we're doing as much physically. Mentally, we're doing more, which is probably better. We should be spending our time thinking instead of doing. So leave the mindless stuff to the robot, right? So again, it comes in, you pin it to the patient, and you make a cut in a similar manner with a standard saw. And then we're not going to wait for them to cut that because it's going to take a while. And then what we do there is we put in a spacer block. So we put a 10 millimeter block in the space that we've made to make sure that that rectangle fits. And if that rectangle fits and the knee gets the full extension, then we've done a good job. We can move on to the rest of the cuts. Again, we won't go through too much of that. I don't want to get too into the weeds of how to do a knee replacement and get a little bit more into just, what you can tell your patients. And if you want to see it, again, it's online. So, yeah, so that's the spacer block we use there. We put it in, we say, all right, great. The knee got straight, and usually test it in varus and valgus. Make sure that it's not wiggling around on you. And then the robot actually gives you this feedback to tell you, okay, he's applying a varus stress right now, and it's not moving. He then applies a valgus stress, it doesn't move. Great, the robot knows that there's no laxity there, and then you're in good shape. So we're gonna stop this video there. And again, the links in the
Two questions for you.
yeah.
I noticed, this person is saying, I've noticed more people with thigh pain and decreased quad activity and extension of the leg.
Okay.
Is this possibly tourniquet? Is it common?
Yeah, so a number of things could feed into that. We'll get to that in a minute. A number of things could feed into that, whether it's tourniquet pain or depending on where those pins go. If you're making the extra pin site and you're going through the quad, absolutely, that can cause that. Probably not related to using the robot, although we are putting 2 extra holes in the femur. I don't know that I've noticed anybody complaining about it, but I also don't see them as frequently as most other people. So that could feed into it. But as far as if you look online and do all your research, the pin sites haven't caused much of a complication. There are some reports of fractures through the pin sites, stuff like that. But as far as thigh pain goes, I haven't noticed the difference.
Okay, and the other question is, have you had any issues correcting substantial varus bulgus knees postoperatively with the other leg or gait?
You mean from a sorry, read that again.
Have you had any issues correcting substantial varus/bulgus knees postoperatively with the other leg? Gait question.
So as far as correcting a lot of deformity, I think this is better than regular instrumentation because it tells us what we've corrected and what we've created. So it tells us if the hip, knee, ankle axis is off. So varus valgus, yeah, you do a good job. I'm not sure what they mean by the other leg. I don't think I want to clarify that, but like if they have both deformities, yeah, I mean, obviously you should use the robot on either side. But it is very good for deformity, and it's really good, especially if they have a deformity in one specific bone. So if there's a deformity, say there's a femur deformity from an old fracture that you can't get a rod up there, or you can't quite reference correctly, this is great. It makes a perfect axis every time. And it makes, say they have a rod in there or something, I don't have to take out the rod. I can just do a knee replacement. I hope that answers the question.
No follow-up.
I have, I need to switch my screen again here. Let's see. Screen sharing is paused. That's not right. How do I get to the, need to share this. Oh, new share, there we go. Hey, all right. All right. This is what, it's not a contest, but that's what Zimmer sent me. This is what Depew sent me. So we'll kind of go through here. This is kind of more of a, we're going to skip this video. This is a, it's like an ad. You guys don't need that. But their registration process is a little bit different. It's a little more streamlined, and I say that as somebody who's currently using ROSA. So they have similar concept though. They take a pointer, they find different spots. Here they are finding the femur. You'll see this is more of a dynamic, move it around, whereas the ROSA was find a point, find a point, find a point. You do the same types of things to find your axis. So right, so you find points on the ankle, points in the knee, points in the hip to figure out where everything goes. The ROSA's got 3 points that it picks on each side of the distal femur, whereas this is kind of more of a painting. It takes like 200 points. So it's faster than getting 3 points, believe it or not, and it's a lot more data. So they'll show that in just a second here.
to have a normal review compartment. So we place
Doesn't actually take this long. They just like to talk during the day. So.
the articular cartilage. On the lateral side, we push the articular cartilage turns to bone to that point. So we've lost 2 millimeters of the femur towards the center.
So here they're finding femur points. There you go. So here they are. They call it painting the condyle. So kind of scribble the pointer on the condyle, and then it takes that data and creates the data or the model in the computer that it needs. Yeah. So yeah, it's good because there's a lot of hips that don't move, right? Not much. If it doesn't move at all, yeah, you're in trouble. You're not going to find a good data point. But as long as the hip moves a little bit, really, you put it in about 30 degrees of flexion. You can move it in a little circle like that. It's going to get what it needs. I haven't had a problem with it yet. Typically, we replace the hip first anyway. So if it's that bad, just replace the hip.
What happens if, I mean, this is all computer driven, what if your Wi-Fi or something happens
Yeah, that's happened.
in the middle?
Yeah, so if the robot stops working, which has happened, you just go to conventional stuff. So you take the pins out and you just get your old, intramedullary guides and all the normal stuff you normally do. So it's not easy to switch because one of the benefits of the robot is that there's not as much stuff in the room. So all the different jigs and stuff we use, you don't need them anymore. So the table's a lot more empty. So if you are going to convert, you got to open like 4 or 5 more trays of instruments and all that stuff. So it is a little bit of a headache, but it doesn't happen often. So here's their screen here is actually a little bit interesting. So what they do is, I didn't show you the soft tissue assessment on the other knee, but we do something similar where we check it at 0 and 90 degrees, we apply varus valgus stress, and then this creates a little graph here, and you can go from flexion to extension. You can gather data points in every degree of flexion and extension from 0 to 90 degrees, and it tells you how loose or tight it is. So in this case, I think this is extension, I think that's flexion. It's a little tight over here on the medial side. So that's data that we use later on. And I think this video shows us a little bit better. And I'm actually not going to play this video. I'm just going to talk about the pictures you see because I think that's the important part. Again, here's that same knee. And we have a mismatch. We want rectangles in flexion, rectangles in extension. And then this is the multiple choice test of what we can do to the implant to figure out how to make those rectangles. So we can put the femur or tibia in varus or valgus. We can rotate the femur. We can take more or less bone. We can add slope to the tibia, and we can flex or extend the femoral component. And using those 6 different things we can change, we can make this into a nice rectangle. So we want, for the diffuse system, it's, I think it's 11, 11, 11, 11, but some people like to change that. And those numbers are more guidelines. There are people who prefer, they say, well, we want to make sure we get flexion. So I'm going to make them a millimeter less tight in flexion than they are in extension. That's going to make it easier for them to flex. And it shouldn't make them unstable. So there are people who aim for 11, 11, 10, 10. And then there are some people who say, well, we want a medial pivot knee. The pivot point of the knee is actually on the medial side. So we want to be able to, as we're flexing and extending, we want the lateral side to move more. So they make a half millimeter tighter on the medial side than they do on the lateral side. This lets us play with those numbers way better than we could with standard instrumentation. You can't do that with, I can't feel a half millimeter difference. I just can't. But the robot can. So it's kind of nice. It gives us a lot more data and a lot more numbers, which is good, but it also probably gets us thinking about things we really don't need to think about. Because how much this matters, I don't know. But too much. All right. You got to watch these on YouTube, I guess, because they're cadaver or they're live tissue. You guys see?
So here we see
So this robot, so you saw before, it was a cutting jig attached to the patient with pins. This is just a saw on a robotic arm. So you're holding the leg, you're making sure you don't hit the soft tissue, and then the saw just goes in the correct plane and makes the cut. So it is a little bit less instrumentation than the Zimmer product, which sounds great. It's a little finicky. It's not terribly easy to use because sometimes you end up fighting the saw a little bit. So they make their cut, they verify, and then it makes its anterior cut. But it is a lot faster because in standard instrumentation, you make your distal cut, and then you have to find your spot for the pins. You put another jig on, you make your cuts to the slots. This you just cut.
Posterior condyles. Finally, the posterior shoulders. And the anterior shoulder. Take the robot, you will see.
So it's pretty cool. The robot kind of moves on its own.
So that hit the bed, so it's out of the way, so it enables us to try the implants.
Going off of the prior x-rays to know what the depth of the bone and so on, fighting bone, not
So
soft tissue. Remember?
So yeah, in the products that we have, oh boy. Sorry, can't walk and chew gum at the same time. All right. So in the initial robot that everybody kind of goes by is the Stryker Mako, and that requires a CT scan, and that uses the CAT scan and the data points you get during surgery, so that if you end up outside the boundaries of the bone, the saw stops and you can't cut anything. It's almost impossible to cut an artery or a ligament with a Mako. Both of our products rely on the surgeon to stop. And the benefit is that you don't need a CAT scan ahead of time. The only way to do that is with some kind of advanced imaging beforehand. So I think that's the trade-off that they made. I think there's maybe one more video. I can't remember what this was. But this is this is just them cutting the tibia. Similar idea, but I think that's all the content that I have for you. We can leave some time for questions. I didn't quite take up your full hour, but a little extra lunch never hurts.
Verification tool that shows extremely accurate cut with exactly what we have.
Find it awkward when you're doing the surgery to have the robot like right next to you. Does it go over?
You get used to it. So yeah, Rosa is an 800-pound big block standing next to you. You learn how to work around it. I can't really speak to the oh boy, automatically going to the next video. Okay. You learn how to work around it. I haven't. I did the training for the Velis. I haven't done it on a patient yet, but I find the saw a little bit awkward. But again, I'm not used to it. There's a learning curve to all this, and I'm sure Dr. Klotz is an incredible surgeon, so I'm sure he's got it down pat already. He's awesome.
I find that there's lots of people in the OR room. I mean, you already mentioned the less instrumentation, but
It forces, so I'm not sure how many people everybody uses to do a knee replacement. I use one assistant, whether I'm using a robot or not. I think there are people who use two assistants. This forces you to use one because the robot takes up a lot of space. Other than that, I don't think so. I think it's probably about the same amount of people, but it's less stuff, at least on the tables. More stuff in the room, but less on the tables.
all of these improvements with treatment outcomes and pain management, do you see in the future possibly them bringing back either double knee replacements or having a shorter window between consecutive knee replacements?
I don't know about a shorter window because I think we leave it out that far just because I think the medical complications go up if you do it in 2 weeks, and I don't think that's going to get better. As far as doing them both at the same time, I don't know. I personally don't like the idea of doing them both at the same time. I think it's a lot of trauma for a patient. Having said that, I think in 2 weeks I'm doing two at the same time. But that's my first time doing it, so. But I don't know. It's a good question. For me personally, no. For other people, maybe.
A higher risk of infection, right?
Yeah, it's longer OR time. Anytime you're exposed longer, it's a higher every complication. Longer surgery is more complications in every way. There are times when it's appropriate, but that's a different topic. for a different day.
So if you're planning to do bilateral, do you use the same robot for each? or do
Yeah,
you
so-
have to have a different robot?
So I think, I mean, if you had 2 robots, you could do it, but the robot takes up so much space, you couldn't have them both in there at the same time. So what you'd probably end up doing is doing a knee, closing everything up, taking everything down, and then just starting over. Because you got to flip the room.
So what's the turnaround time on?
So the robot is covered in a plastic sheet. That just comes off, and then that's pretty much it. It's not that long to clean it. It's more moving around and getting it in the right spot and all that stuff. That takes time. I don't think like my OR turnovers aren't any different now than they were. I don't know.
There's a question. It says, does the ROSA replace the patellar component as well, or just femur and tibia?
Yeah, so both products only do femur and tibia. The patella is still on us to cut it. It's such a small bone. One of the principles of the robotics or navigation systems, or whichever one you choose to use, is that you have to have some kind of reference point or pin or something in the bone that you're working on. Patella is such a small bone that getting a reference point or pin in there is just not feasible.
Has the materials changed that you use, or you still use like titanium?
Yeah,
for
they're
robotics, or like, is that?
all the same. Yeah, so the base plate of, and I'll speak to the Zimmer implant just because that's one I use and I know. The base plate is a titanium alloy, high molecular weight polyethylene liner, and then the femur is cobalt chrome. They do have titanium femurs, but they're just they're not. They're a little more expensive, so they use the cobalt chrome by default, and then we use the titanium ones for metal allergies or whatever. But yeah, the implants that go in, whether you're using a robot or not, are exactly the same.
You have a dedicated assistant running the actual system itself during the surgery, or is that not you?
So the scrub techs are all trained in it, and then there's a representative from the company. So there's always a DePuy or Zimmer rep in the room running the robot and kind of navigating through the screens. With the Zimmer robot, you have to have somebody else there. With the DePuy robot, there's an option for an extra station that they put a sterile drape over, and you can do the touchscreen yourself. But I think most people just have the implant rep running because they're there anyway. They're going to be there for the knee replacement anyway. So. I hope that was at least a little bit informative. If you ever have any questions, feel free to email, call, text. You can get my number out to whoever. They can let me know anytime.
Thank you.
If you guys could, if anybody didn't sign in, can you just sign in on the? One over here, there is a few snacks if you want.
Yeah, I hope that's what you guys were going for.
Yes, it was exactly.
Hello. Hi.
I can give you your laptop right back. You want it?
Good, how are you?
What I wanted to, yeah, go ahead. I just wanted to, are we done recording?
No, we're still recording. So we can stop it there.